Welcome, Health Impact audience. We've got a jam-packed next 30 minutes for you to talk with some folks that you guys already know as luminaries in the field. I mean, these are CIOs that you've heard speak at many places and, basically pontificate about great things that all of us should be doing as health system executives. But we wanted to choose a different angle to talk to them about their patient experience as a CIO in their own or related hospitals and health systems. So this discussion really is about why and how we put patients in the driver's seat and get some really game-changing lessons from these CIOs who know what's like to put technologies front and center in front of patients. But now with that patient view, would they change anything? What would they suggest senior executives do about technology and how technology is applied from that patient angle? So we've got Pamela and Cris to talk to us. I'm going to have Pamela introduce herself first, then we'll go to Cris, and then we'll just jump into a quick conversation. Pamela.
Excellent. I've been a CIO in several other organizations, but the last 14 years, CIO at Children's Health in Dallas. And I'm currently serving as the SVP of Strategic Technology. I've seen a lot of growth from one campus to three. We continue to grow. It's a growing market. Migrated an EMR, built data centers, and then migrated to the cloud. So there's been a lot of change over time. And necessity is the mother of invention. And you see a lot of virtual these days as well, especially in light of COVID. But at the beginning of 2020, just when COVID hit the US, I was with a children's health team touring best practice hospitals on the West Coast, gathering ideas to future-proof a new tower we're building, as well as some future facilities. And I checked into my hotel after a full day of touring, and my primary care physician had left me an urgent message to phone her on her cell phone anytime. Not the kind of message you want to get from your clinician. I not only had breast cancer, but an aggressive cancer, and I needed to see a specialist soon. I had no idea the prevalence of breast cancer. I had no markers or family history for it, but 1 in 8 women, 1 in 8 of your female friends, family, and neighbors or colleagues will have breast cancer. Thankfully, the treatment has come so far. I saw precision medicine in action. The team of talented UT Southwestern clinicians over the last year and a half, I say they saved my life, and they guided me through my tour of chemo, infusions, multiple surgeries, radiation, and reconstruction. I witnessed firsthand the caring, and I am grateful and humbled.
Awesome. No, and we're pleased that you're with us here. And unfortunately that you had to go through that experience, but we'll put a positive spin on it and get as much of that experience embedded into healthcare information technology at both your role where you are and of course teaching our other health system executives as well. Cris, tell us a little bit about yourself and your role at Mayo, and then your story, just like Pamela's.
Sure. Thanks, Shahid, and thanks for Health Impact for having us here. I'm Cris Ross, and I'm CIO at Mayo Clinic. I've been at Mayo for about 8 years. How I came to the patient side was in July of 2018. I was diagnosed with a stage 3 colorectal cancer. Went through the normal course of treatment, which was chemotherapy, then radiation, then surgery. I was declared cancer-free in March, had a subsequent surgery a couple of weeks later, and I was back on the job in June of 2019. And, I forgot about cancer for quite a while. And then in January of 2021, I was diagnosed with a recurrence of colorectal cancer, some cells that, were in the same sort of area. So again, back into the fight, chemotherapy, radiation, a little bit different chemotherapy, a little bit different radiation this time, and then surgery on July 15th of this year. I spent a month in the hospital afterwards, and I'm happy to be looking forward to getting back on the job next week. But both have been interesting journeys, to say the least.
Yeah, to say the least, as you said. So in this case, Pamela, we'll start with you. Tell us about any friction points at the hospital and health systems that you visited that maybe did not have to have the friction, and maybe you would have missed if you were not a patient. So did you notice certain things and were able to say to those around you, hey, why is this working this way? And would patients have been able to say the same thing if they didn't have your role and your background and experience as a CIO?
Absolutely. First, I'm going to start with just one thing that worked right that I don't think patients take advantage of. The patient portal. I was always a huge fan, but now that I've been a frequent flyer patient, I am a tremendous fan of the patient portal. And it really isn't the window into your electronic medical record, and it's invaluable. You can find out about your labs that you just took before the clinicians even get back with you right away. As far as appointments, you can request appointments, or you can actually schedule appointments and find out the location. I went to an academic medical center and things were scattered to different buildings, and that patient portal, I was always pulling it up to make sure I went to the correct building for this particular area. Messaging your care provider, actively engaging in your care. This window into the EMR is invaluable, and so many patients do not take advantage of it. So that's something that works right, and people need to use it more. Some of the things that I saw challenged. One was the data flow among different caregiver organizations. I mainly saw this when I was getting a second opinion and working with a couple organizations in my primary care physician as far as my history. And in this case, it was a classic case of 3 different EMRs, difficulty transferring information. And in this case, it wasn't fax, but sneaker net. And it's sad that it still has to take place. But I will say, this is something that all the organizations have to come together, and to fix it tends to be non-glamorous work. So sometimes a patient making the statement that this is important to them is going to make a big difference. It's the one area that had me screaming through all this. Second area of challenge was refinement and workflow. If you think about any kind of change, sometimes it trips up the electronic medical record that is geared to certain things. You have complex care, a lot of different parties are engaged. Well, I'll give one example. In one surgery, I had a port, but the system didn't quite know it, so they were sticking me with a needle when I didn't need to. So I would have passed on that if I didn't have to. And then with one of my surgeries, they took the port out, and I arrived and the system thought the port was still there. So those are just little hiccups, but I think the key that any patient should know is that if they see something that doesn't make sense, you're in organizations that want to deliver the best care possible. And if you're vocal about some of these challenges, they will get fixed. But at the same time, you want them fixed now relative to your own situation. So you need to be vocal along the way. And the other comment I'd make is my fiance's had recent cardiac surgery. And I think that the notification along the way with the surgery, now I'm talking about a patient family member looking after their loved one. I thought that the UT Southwestern did a reasonable job, but I will offer there's so many areas where text message notification can be interjected into the workflow processes, and allowing people to select their preferences on how they're notified along the way, as far as when one of your loved ones are having surgery. But I'll stop there. The list is long, but overall, I'd say great experience as far as the care delivery, but every health system has opportunity with the patient experience.
Yeah, I love it. And in fact, Pamela, as you were talking about that point of being vocal, maybe I'd love for Cris, for you to jump in and kind of like take that and add to it and say, how would one be vocal? Like, is there a process? Is there a procedure? Is there a technique that you would say? I mean, both of you, when you were within your organizations, knew what happens in a hospital. So you had better insights on what maybe to expect, what not to expect. So that's one area, Cris, is to say, how can one be vocal? And at the same time, talk about, I know that you and Ed Marx are working on a book that might basically help patients understand this process a little bit better. And so you're welcome to weave in what you're working on that book in terms of allowing patients to be more vocal. And then we'll have Pamela jump back in and comment on what you say as well. So tell us about how to be more vocal, and did you find friction points?
Sure. Well, I think being vocal is a perfectly legitimate thing for a patient to do. But I would say in general, the thing that Ed and I have talked a lot about is that all patient journeys, the success of them really depends on what attitude the patient takes. How do you want to get through the system? So I would say, for example, your question about friction points, I think every patient should expect that there's going to be friction points. A health journey is not like a ride at Disney World, where you know that you're going to get on in the beginning and you're going to get off at the end and everyone's going to have a good experience. It's like a trip to a foreign country. There's going to be a missed reservation. There's going to be a lousy restaurant that you go to. Maybe somebody's going to get sick along the way. You're going to be disappointed that a museum you wanted to see is closed. You know, that's more like what a healthcare experience is going to be. It's not curated. It's not perfect. It's not scripted. It's an adventure along the way, hopefully with insights gained by you and your clinician along the way that'll help adjust your care. That certainly happened for me. So I don't want to excuse hospitals and say, go ahead and deliver a lousy patient experience. Far from it. But I also think it's important for patients to understand that they need to be part of the decision-making process. They need to take on board the fact that they need to be resilient and understand that there's going to be things that happen along the way. With that in mind, I would heartily second Pamela's endorsement of Patient Portal. Holy smokes. The Mayo Clinic patient app was my companion through 2 long journeys. And, like Pamela's experience, we have open notes. So I can see the full surgical notes. I can see the full report from the radiologists. I can get everything. That can be overwhelming for some patients. Some people might look at it and say, I don't understand this. This language is complicated. It scares me. I don't know what it means. You know what? For some patients, don't look at the portal details.
Right.
But do keep track of where your appointments are going to be, and make sure that you know what questions you want to ask and what anxieties you want to express. I certainly had a fantastic journey through Mayo Clinic twice. Because it was an integrated system, I didn't have any of the problems of data being exchanged from multiple systems and so on. But even within that wonderful system, I certainly had friction points. There was an occasion during my care when I needed to have a nasal gastric tube removed. If you've ever had a nasal gastric tube put in, it's the last thing you want. It's a pretty bad thing. It's like getting punched in the nose and then choked and gagged. I didn't want to take the tube out until I was sure that the underlying cause had been addressed. And I had a resident on a Sunday morning who announced that the protocol said that the tube should come out. And I simply disagreed. And we went around and around. And I finally said to the resident, I'm sorry, we just don't have a meeting of the minds here. Mm-hmm. I'm the patient here, and I just don't consent to have the tube removed. This is what I would like before I had the tube removed. Sorry if I'm giving too gross of an example.
Perfect example.
But it's a place where, honestly, I needed to stand up and say, no, I'm not comfortable with you doing this. I understand your viewpoint, but I disagree.
Right. That's perfect. And when you look at that comment, Pamela, then, so you mentioned being vocal. I think Cris added very nicely to that to say it's about your attitude. I mean, if you feel like everything's going to be perfect, and then even the slightest thing goes wrong, everything looks bad. If you feel like you have no control over anything, then you let everything happen to you, which is also bad. What would you suggest that hospitals and health systems, especially the executives, should do in terms of I don't know, training is probably a bad word. Educating patients is probably a bad word, but what should patients be told on the way in that, hey, if you see this, it's okay to talk about it. Hey, it's okay to question your nurse and your doctor. You're not going to be insulting them, for example. If somebody says something to you and you don't understand, ask someone else to explain it. You won't be insulting the nurse or you won't be insulting the doctor, because a lot of this is kind of like a paternalistic environment when you go to a hospital and you're feeling like, wow, they know what they're doing. I shouldn't ask, right? Or I shouldn't question. Well, how should that training occur from the senior executives on down when they're bringing patients into the hospital for these complex procedures, Pamela?
Very good question. And I do agree with Chris's comments that it really is a journey to another country. And you want people to have a flexible attitude. I'd also offer that when I say vocal, I don't mean that people are like in your face mean about what they want. Because honestly, when you go into health systems, these are people who really care and they're doing their best for you. Right. So from that standpoint, but relative to permeating the entire organization, from the senior leadership to the front lines, that emphasis on patient experience is very important. I'm going to echo what Cris just offered is somebody might love the portal. Some people may just need to be aware of the portal and then they'll love the portal. And then there's other people who that isn't how they want to get their information. I'd offer that my father, who's close to 90 now, would not want his information through the portal, but certainly others in his family will want to translate. But so that whole aspect of really reading what that patient family wants, because we're a pediatric organization, so it's about the parents as well, but what that patient family wants, in those instances, that comes from the top. And I will say that at Children's Health, we have initiatives that really get into all aspects of the patient experience, and there's still a long way to go. Relative to awareness, I do think that sometimes people aren't aware of what they can be doing with their data. And in those instances, when data doesn't flow, do they want the data shared? All of that kind of information is an education process. And it needs to happen where the patient's at in that care journey. We do a lot of that with our medical records department, where patients tend to reach out when they need some of the information and they want to share it in other enterprises. But as far as that aspect of educating the patient, I think the more places you do that, the more likely patients are going to take advantage of it. And relative to notification and workflow, I will also offer that at UT Southwestern, they were surveying every time I had a clinic visit, every time I had a surgery. The organizations want to hear from you. And I think as a patient, sometimes people don't realize that that information is read and some action is taken based on the feedback that they give. Certainly, if you have positive things to say, the caregivers need to hear that, the organizations need to hear that so they don't break what's working well. But they also need to hear the areas where you'd like to see something different. Whether you're used to Alexa at home and they want to be able to use Alexa in their hospital room, to difficulties getting a ride if they have some challenges there. There's a lot of things that you can give feedback to the health systems on, and they sincerely look at it and they change behavior based on that. Yeah. I'll pause just to see if Cris has something else to add.
Yeah, I'll ask Cris to jump in, but I wanted you to elaborate on one key area, and that is, most of us when we fly, it's to a point where we're sick and tired of it. But when the flight attendants get up and tell us the safety video, right? Basically, here are all the things that you should expect from this plane. If it goes down, you're going to do this, and you put your head down if you see something. If everybody else is putting your head down, you put your head down. That kind of safety instruction seems to be something that hospitals should do when you walk in, right? You're about to go through this pathway. Should you be told, here's what you're generally going to expect. We want your input. if that happened, if you do that at children's, because I know at a children's hospital, you're more likely to do that because patients literally don't know, like children don't know and their parents don't know what to expect. So what should almost like a flight safety video or a flight safety instruction look like, Pamela, from your perspective? And I'd love for Cris to kind of like add on to that. And then basically teach senior executives about how they should educate. And then basically after that, we'll talk about what would you do with that education after you did it and people gave you information. So tell us, what would a safety video look like for patients based on your experience?
I will say that there have been educational videos that when I was in the hospital room relative to my condition, there was very detailed videos that you could put on the TV, and it marked whether you watched them or not, which is very helpful relative to the health systems knowing that you consume that information. The other aspect of it is how you make it kind of seamless. They end up knowing when they need to know. So relative to our portal, we also put a wrapper around it, and you can actually GPS from your home all the way to the floor of the clinic and to the clinic itself. Those kinds of mappings of what people need to know, when they need to know it, similar to when you're driving down the highway and you get guidance from your GPS that you're taking your right-hand turn. If it tells you a mile early, it's not helpful. It's like when you want to know it, that's when you want to know it. So relative to what that video, what that orientation could look like, similar to whether people like text messages in the portal, everybody's going to be slightly different, and you need to meet the patients where they live, learn, work, and play. So you have to kind of look at those health journeys. And I will say there's probably some 80-20 rule aspect of being able to get a good corral of patients with the approach. We try to leverage our wrapper around our EMR portal as much as possible, because a lot of our patient families like that as a location based on the feedback that we've been getting. But you have to recognize every patient is different, and it's okay. And in some cases, they might be in that 20% where the feedback is going to make a difference around some of the other alternatives. But it really does depend on your condition. Certainly, my cancer journey was different than Chris's. And if you're there to get a different type of procedure done, it's going to make a difference on what that orientation video looks like. There's some basic stuff on where to park and that sort of thing. And then there's the other aspect of your particular clinical care journey.
Yeah, that's great advice. And Cris, if you can talk a little bit about, as you experienced it, you did this experience like twice in 2 years, right? So you went through it once and then you came back. Most of that was probably consistent because it was only 1 year apart. But as you think about that, when you came in, you probably forgot certain things you would want to have been reminded of. Should the safety video, quote unquote, include things like, here's what you can do with your patient portal. Here's how you should speak up. How much of the, so I've seen certainly the videos and things like that, as Pamela's mentioning, about the procedure you're going to go through. But really, the rest of the experience is left kind of as an exercise to the reader, as it were. And how much, Cris, do you think we should tell senior executives at hospitals and health systems about how to enunciate, elucidate, explain what people should expect? And then when they don't get what they expect, that there's a way of telling through surveys and things like Pamela mentioned to be able to then take that and do something with it. Any comments on what senior executives could and should do?
Sure. So I would say, I don't speak for Mayo on this particular issue because it's not my portfolio. I'm the CIO, but I certainly intend to be provocative and mouthy in the appropriate kinds of ways to get from here to there. I think that we have examples all around us that could inform us. Think about old commercials for products or services. I happened to come across a manual for a car from the 1950s, and the manual said nothing about the driver or the passenger. It was all about the maintenance of this physical device. The whole thing was How's this product work? The car companies now have become lifestyle companies. Look at some of the ads that are coming out from places like Toyota. That one ad that was run incessantly during the Olympics about a car that's your friend and plays karaoke and drives for you. I think the car manufacturers have understood that they can cross that sort of, fourth wall, as it were, and not just talk about the car and the mechanics, but they can talk about the driver experience. And who are you? What lifestyle do you have, and what kind of car do you want to have? I think it's going to be okay for healthcare systems to break that fourth wall and kind of meet the patient where they're at. So I would say, in my personal experience, I got these really nice patient appointment guides, both on the portal and occasionally they got printed out for me for whatever reason. And, they told me that I needed to fast and what I could do the next day and what to expect and what this procedure was all about. And I felt pretty informed. But there were some other places where there was some hits and misses, right? Where I think more transparency with the patient could be a better thing. So, for example, in this last surgery that I had to remove the cancer, is a complicated surgery. There were 6 teams involved in the surgery. The lead surgeon did a really great job describing everything. And I met with all of the surgeons who were going to operate on me, and they all explained everything to me. And yet, when it was done, I came out of that surgery with nerve damage because of where the tumor was located and what was required to take it out. And I don't have use of my left leg. And I'm in the process of rehabilitating my left leg. And now I guess I'm an advocate for the disabled because I'm experienced what it's like to be disabled for a couple of months. It would have been helpful to me if at some point, even some more dire potential outcomes had been more fully described to me. And I'm sure that's scary to a clinician. I got a lot of dire outcomes. I was well understood the possibilities of many things that could go bad. But even with that, it would have been helpful to take even a step further to describe some potential outcomes.
Yeah, and when you think about that as a potential outcomes, could there be either technology or other education material about what has happened with similar patients, your age, your gender, your past, your current occupation, and that kind of thing, is to say, here's the 400 that were done in the last 2 years. Here is the outcomes that they have seen. Now that gets a little tricky because I think of what Pamela was saying, which is how much is too much information. And so when you think about that, would you err on the side, as a patient, would you err on the side of getting too much information, assuming that there is a group of loved ones around them? Or would you say it's better to give them only the stuff that they need? And if there's not a family or a group around them, don't give them more than that. What's just some of your opinions there? And I think you can go first, Cris, and then we'll bring in Pamela.
Sure. So I really like what you talk about the kind of village surrounding the patient. That's a theme that's been pretty important to me, and it's going to show up in this book that Ed and I write, which is how much people do depend on that support structure for lots of stuff. Look, I think it's going to be impossible. I just sort of complained a little bit about my circumstance. I think it's going to be impossible to provide a guide to everyone that covers everything, number one. Number two, I think it's the case that part of this has to be, what can the patient absorb and what can they express about their ability to absorb things? Some people are easily overwhelmed with too much data or too much feeling. Is it serving them to load more information or more anxieties on them? Probably not. So I think, clinicians are in a damned if you do and a damned if you don't kind of position. So again, I think the viewpoint is the patient, from my experience and observing the way the healthcare system works, the patient ought to make a decision the best they can about what is their flavor of journey. What will be the thematics that guide them through? Do they want to know everything? Do they not want to know everything? Do they want to take a, cancer, I'm going to crush cancer journey, which a lot of patients take, or are they going to take a more passive one, which is, I trust the clinicians and I'm going to see what comes out the other side. I think it really is incumbent on the patient to decide, what their adventure is going to look like and what kind of attitude are they going to bring into it as best they know. They certainly can change their mind as they go. But I think the more you're true to yourself, the better chance you're going to have to get the right kind of information at the right time.
Yeah, and Pamela, when you think about extending on what Cris was saying with respect to what to tell senior executives about how to change a hospital health system, when you look at it in terms of the patient relationship, it seems like hospitals like to have a relationship with the patient. They don't know what to do with everyone else around them. Is that a reasonable statement, number one? And number two, what could we do going forward to say, look, guys, the patient, aside from HIPAA, there are real actual HIPAA problems. I'm not saying that somehow what I'm about to say is easy from a regulatory perspective, but if family members are always, like when my mom recently had her cancer surgery, she was not alone at any time, ever, right, at the hospital, meaning not just hospital staff, but every day there were one or more family members. And the hardest thing was for the family member to tell what the next family member was coming to take over the shift was. So that became a struggle because the hospital perfectly reasonably did not know who was a family member, who wasn't. But that also seems like something that could be solved if we assume that a caregiver, kind of like that mini village that Cris said, is a norm in many cases. And that could hospitals and health system executives do something about that, Pamela? Or is that going well beyond what HIPAA would allow?
No, actually, patients can indicate who they want to have their information shared with. So I don't think HIPAA is a barrier there. The key is the patients in the driver's seat there as far as determining who's going to get to see the information about what's taking place at that point. I'd also offer that relative to pediatrics, if you look at how that patient experience is designed, there is the assumption that there's a parent that needs to know about the decisions that need to be made. I would say in the case of my 90-year-old father, I think that there's a daughter or another family member that is part of that care group as far as that support structure. So I think when we look at adult care, I know that the EMRs have these capabilities. So some of it's a workflow aspect of building it into the workflows of allocating those people, educating those people on the use of portals and different tools. I am going to also mention that relative to what Cris was offering, he would have liked to have known certain outcomes before having gone through the procedure. I saw Dr. Halamka, who's with Mayo, speak at a HealthIMPACT conference, and his wife had breast cancer. Now, you could offer Dr. Halamka is a very sophisticated, not only clinician, but also he understands technology quite thoroughly. In any case, what I'd offer is that in time, I think the data around the statistics with your particular condition is going to get more aggregated. Some of the EMR vendors are aggregating the information across all these different health systems. And in doing so, that's not only going to be helpful to the physicians that are actually doing their research, the bench to bedside kind of research. We want it at the bedside or clinic side where it's actually being received by many patients. There's forks in the road. I think that it won't only be for the physician, so it'll also be for the sophisticated patient that wants to know the stats. And I will offer that at UT Southwestern, they were incredibly patient with me asking a litany of questions. And when they give me an answer, I'd say, you don't have to give me the exact step, but I want a directional statistic on this so I can make my choice. In those forks in the road, I think that people do want some data to marry up with what is recommended. And in fairness to health systems, that whole data being aggregated across all of the health systems, That's only really starting now in some academic medical centers where they had some agreements across academic medical centers, but getting a bigger denominator starts to make that data more relevant. And if you have a unique condition, there's more likely that they have something that's a meaningful percentage if they have more patients that actually fit in that window. I'll pause there. I am curious if Cris agrees with me on that.
Yeah, and Cris, definitely add on and do answer Pamela's question about that if you agree, but maybe take this one step further for our health system executives. If you do open up and accept patients being more vocal, because we want them to be, you accept the idea that you're going to train them a little bit more, educate them a little bit more about what experience to expect. When they have input, though, what are you supposed to do? Because it's one thing to not ask and then not deliver. But if you ask for vocal input and then don't deliver, things might be worse. So just to take us home in a couple of minutes, just tell us about this, and then we'll conclude for this afternoon.
So when I talk to my clinician colleagues at Mayo, I don't think we have a shortage of vocal patients. They are, come in with viewpoints about their care and so on. Mayo focuses on complex and serious disease. So people are highly engaged, justifiably so. And we've seen examples nationwide of where vocal patients, in the COVID pandemic, for example, are, asking for particular medical cures which have become popular, which are not clinically appropriate. Well, what do you do with the patient who insists on receiving those kinds of unapproved and unproven therapies? I think this is a tough job for clinicians. We've even seen cases where there's been lawsuits, right, to force a clinician to deliver a certain kind of therapy. So I think the idea of that there's probably a lot of people who we could encourage to speak up more. Mm-hmm. And there's probably a lot of people who we could encourage to become more engaged in their healthcare, especially when you think about issues around non-compliance for chronic disease, where people are not taking their medications or they're not eating or exercising in alignment with what their treatment program should be like. So I think there's a possibility of focusing in on those folks who might be silent or who might be disengaged with their health in a way that's not as positive. I don't know what the answer is for that. There's a clinician at Mayo, Dr. Victor Montori, who worked on a thing called shared decision making for a long time, and it was very simple things. It was you would often one of the artifacts to be used was a simple piece of paper with a sort of dots on it that would show the number of people who have this disease and take this medicine and have a heart attack, or is this small little number of red dots at the bottom, and people who didn't take the medicine, there's a lot more red dots. Very simple, sure, but perhaps that's the kind of thing that's necessary to meet that non-compliant patient in the right place. So anyway, I'd worry about folks like that rather than the others. How do health systems handle those vocal patients? I think we're learning how to do it. I think we're learning how to be more like lifestyle companies, like the car companies, where we cross that line and are willing to talk to the patient about what they want, what are their goals, and so on. I think that's a wonderful thing.
Yeah, and I think maybe just in the last minute that we have, if EHRs were assumed to not be the hospital's system of record, and instead were the patient journey management system, as it were, when they were at the hospital, starting with, and I love Cris, the point that you made, which is that don't focus on, so ask some very simple questions to know whether this was going to be a vocal patient anyway. Maybe you kind of quote ignore, not in the same way, but you don't have to focus on the ones who are going to be vocal anyway. You want to hit the maybe quiet majority of 50, 60, 70% to give them special attention, because they're going to be silent and they will actually get worse outcomes if you don't walk them through the thing. So maybe it's the opposite. don't focus on the vocals at all, focus on the ones that aren't going to be speaking up, because that silent majority, one, will have the most common experience, but when something goes wrong, they're the least likely to speak up. And maybe that's what we should be teaching our executives to do, is giving them techniques to find those that will not speak up and raise their ability to do so. Just in the last 30 seconds or so, Pamela, what do you think about that idea? And then we'll let Cris answer.
It's an interesting idea. I do think you always want to encourage the patients, and I think the clinicians really try to reach out to encourage the patients to engage in their care. Back to my comment around statistics that possibly can be fed back to a patient. It's probably those that are not converted, the ones that are disengaged, that to Chris's point would be influenced the most. If they can see, well, if you continue down this path, kind of like a Christmas Carol, here's what the outcomes could look like. But relative to the people who do want the data, the ones that are vocal, I will say that as they see forks in the road, I love this, the work that's been done at Mayo as far as figuring out how to engage them and get the information to them along those forks in the road. I think the ones that are already engaged are probably going to consume it more readily. And in those instances, we have opportunities. But anything we can do to make the patient experience so that it feels like it's where they live, learn, and play and work, it's going to be much more positive. And they've made a lot of steps in that direction, I've found. So it's been encouraging to me, where you can even get a shot at home where it's on a timer, and the next day you get this shot and you don't have to even go back in for a follow-up that normally you'd have to be back in their walls for. But I'll pause there and give it back to Cris.
Yeah, Cris, in the last 30 seconds, tell us a little bit more about the book itself, and what, if any, input would you like from the HealthIMPACT audience? We've got a bunch of smart people. What could they send you in terms of emails or interact with you about some ideas you may want from the community, if anything?
Well, Ed and I would love to hear from everyone. That would be great. I think our viewpoint was to simply take our experiences and to, with the helpful input from our publishers and editors, into a book for patients as opposed to a book for health systems. So we're pivoting a little bit and doing a little bit of rewriting. But our focus has been to encourage people to think about what kind of attitude they want to bring into their health journey. How are they going to use their friends and families around them? How are they going to engage with their care team? And then we want to kind of draw the curtain back a little bit about why are health systems so complex? Why are some things difficult that look like they should be really simple? But Shahid, I love your idea about the EHR being the patient journey map. I don't think it needs to be either or. I think it can be the patient system of record plus the patient journey map. I love the idea of having some sort of journey map that can be edited by the patient that helps them understand how they're going to get through their care to the end. It's a powerful idea, and it's the kind of thing we should be looking for.
Fantastic. Great advice, Pamela, as usual. We've had you on multiple times. Cris, we've had you on multiple times. You're always welcome back. So hopefully you never have to go through the experience that either one of our esteemed speakers have gone through. But if you did, you'll get some lessons here. Be a little bit more vocal where you can, pay attention, and have a great attitude, which will hopefully drive you in that comparable to a foreign country visit more than an entertainment type of visit. So great advice as usual. And with that, I'll turn it over so we can hit our next session at the HealthIMPACT.
Thank you.